Hello, I'm back now after a long time for my online residency program. Okay, I'll be recording this for myself, and if I want to share it with somebody who's also doing online residency program, but basically for myself. Okay, so for now, let me share with you how a residency program looks like. So this is the online access to all my courses. They have already posted all the courses that I'll be studying until January 27 next year. So now I still have to focus on finishing this pathways to safer opioid use, which is what I'll be doing at the moment. Okay, let's start.
Welcome to Pathways to Safer Opioid Use. The goal of this simulation is to demonstrate best practices in safe opioid use and prevent adverse drug events. You will play as 4 individuals, make decisions for them, and see how those decisions play out. Click the right arrow to begin the program.
Okay.
A normal day is filled with hundreds of events.
Dr. Bright.
Hello, this is Detective Ben Sadikman from the County Police.
Hello, sir.
Events that don't require a second look.
I'm doing a follow-up on the James Parker overdose.
Uh-huh.
I want to know the patient's condition.
Excuse me, I'm sorry. You said James Parker.
Yeah, James Parker.
Then there are events.
Overdose? What's his condition? What happened?
We need to know what happened. Explanations protect us from a universe of random events. They help fill the emptiness if things went wrong.
What happened?
Explanations are how we learn from cause and effect. But will we do anything with what happened? It started with pain.
Oh! Ah!
The irony is, it's there to protect us. James Parker had been a police officer. The back injury that took his career started taking his sanity due to chronic pain. Pain medication was the only option he knew that allowed him to do anything.
Are you okay, sir?
Yeah, sorry, I don't have fond memories of hospitals. Long story short, I fell. I think I hurt my eye.
Corneal abrasion. It's gonna hurt a lot for a few days. And you'll need to start antibiotic eye drops right away. I'll write a prescription for the eye drops, a few days of hydrocodone, painkiller.
James could have volunteered that he was on other pain medication, but he didn't. He gave his medication history to the nurse, and it didn't seem like the physician had read it.
Can I just get the meds tomorrow? It's 3 a.m.
Infection is your big risk. You need to take the eye drops before you sleep. There's a 24-hour pharmacy just down the road.
And he just did what the doctor told him, and didn't go to his normal pharmacy that had his records. He didn't know what questions to ask, and he didn't speak up. Turns out, he didn't use the new pain medication when he got home. He slept for a few hours before an unrelated appointment at his primary care office. Nurse Rhonda saw him, but didn't see all of him.
I've been stuck on the couch for 2 days.
The back?
Yeah. Oh, and last night I go to get up and I move the wrong way and I fall. I had to go to the ER because I hit my eye on the way down.
The eye okay?
Yeah, they gave me antibiotic drops.
And instead of telling Dr. Bright personally,
Be sure to tell Dr. Bright about the ER visit.
she delegated communication to the patient.
Another piece of me that's not working right anymore.
And if she suspected his depression, she didn't feel empowered to act on it or bring it up with the physician. Just one more event where little information was shared between the healthcare team.
How is he?
In pain, lots of couch time.
Thanks.
Dr. Bright could have discovered what he needed to know, but he had his head down.
Alcohol?
Rarely.
More clicks during a visit meant fewer between visits, tighter scheduling, and finally,
Everything I'm hearing is saying that you need a bump in your pain medication.
Really? I mean, I fell last night just from moving wrong.
You okay?
Yeah, but did I fall because I was in so much pain or because I was so whacked out on medication?
and though he'd finally looked up,
What do you think?
Man, I don't know. I'm sick of this. I hurt.
Dr. Bright didn't take the time to work with the patient to make informed decisions together.
Let's move you to 15 milligrams oxycodone extended release. See if that helps.
He turned to opioids rather than alternatives, and he never considered that psychosocial reasons had kept James on the couch. And when the nurse saw him again to counsel him on proper use of the new medication, she also assumed.
No questions.
You sure?
Yeah, I got it.
She never engaged in teach back. She didn't take time to fully confirm what he understood. It's not that all prescriptions for pain are wrong, but the ones about to collide in James were.
You okay, sir?
Well, bad back, kind of just like to get home.
Okay. I'll be right back.
Thanks.
He was a regular, so she never checked the prescription drug monitoring program and never called his physician about the higher dose. And everyone thought that.
Do you have any questions about the new medication?
Do you have any questions about the medication?
Do you have any questions about the medication?
Was all that a responsible practitioner had to say. Yet, Dr. Lee still saw something in his body language, something unsaid or unasked. But
Sorry, I messed up. She's been waiting.
Long day, huh?
and she didn't pursue a conversation. She didn't question. She just covered her bases.
Here's the dosage. Here are the warnings, possible side effects.
Okay.
He wasn't engaged. He didn't make it easy on those responsible for his safety. Explanations aren't always easy. And like so many of us, he may have been looking for pills to do too much. No one offered him a broader concept of treatment. In small cravings for relief or larger feelings of emptiness, it all added up to taking too much. Dad. Dad. Mom! Mom! James? James! James! Call 911. Okay. Come on. Come on, James, babe. Come on.
I don't know what happened to my dad.
James.
I just won't wake up.
What's going on?
My daughter came down a little bit ago. She found him like this. He's not waking up.
What's his name?
James Parker.
James,
he was on
Mr.
some-
Parker. 2, 3, lift.
By the time naloxone was given, he was in circulatory collapse. His oxygen-starved brain was barely alive. And that's how it remained.
My guess is he senses us. He knows about the diaper changes. He senses the tube feedings, and he hears our voices. And along with his back full of pain, he feels an emotional regret he doesn't completely understand.
When no one else is present, some places in our lives feel so empty. But it doesn't have to be this way, because this is not reality. You've got a second chance to change what happens. You can become 4 of these people, make new decisions about how to safely manage pain and prevent adverse drug events, and perhaps change the outcome. Get it? This is you, this is you, this is you, and this is you.
Try to make different decisions in the lives of these people and see how those decisions affect the outcome. With those we lose to prescription drug overdose every year, we could fill all of these seats, dozens of times. Let's try to work on what happens.
Select a character to begin the interactive simulation. This is you, an experienced med-surg nurse who transferred to primary care 5 years ago.
Hey,
Something is different.
Donut? Muffin?
breakfast? What's going on?
You didn't see the news?
Dr. Bright, the director of the practice. Great person, great boss.
News?
Right? Why would you check work emails after hours?
Dr. Schreiber. There are reasons she's not the boss.
We lost Jane.
This day turned out to be one of those days that life changes.
Loss? She needed to go carpe her diem. She sent an email and brought us breakfast. You just missed her.
Oh, Jane?
Did I mention Jane was a senior RN and the pain resource nurse?
Take 5 minutes and meet me in my office. We have to talk about your new pain patients. This is a good opportunity.
Me? Pain?
Change is often confusing at first.
Safe opioid use and the prevention of adverse drug events are critical tasks for healthcare providers. Chronic pain is reported by over 100 million Americans annually, with pain affecting more Americans than diabetes, heart diseases, and cancer combined. There is a general consensus from experts that the undertreatment of pain is a major problem. Yet, growth in the amount of pain medication dispensed in our society is correlated with increases in prescription misuse and abuse. Opioid overdose deaths have recently surpassed motor vehicular accidents, making it the single most common cause of accidental death. Healthcare providers don't have to choose between successfully treating pain and stopping ADEs. With education and training, healthcare providers can reduce opioid-related ADEs. What are adverse drug events? Adverse drug events have been defined as an injury resulting from medical intervention related to a drug. ADEs can include, but are not limited to, medication errors, adverse drug reactions, allergic reactions, and overdoses. ADEs can occur in any healthcare setting, including inpatient, outpatient, and long-term care settings. Given the U.S. population's large and over-increasing magnitude of medication exposure, the potential for harms from ADEs constitutes a critical patient safety and public health challenge. In patient settings, ADEs comprise an estimated 1/3 of all hospital adverse events, affect approximately 2 million hospital stays annually, and prolong hospital length of stay by approximately 1.7 to 4.6 days. Outpatient settings, ADEs account for over 3.5 million physician visits, an estimated 1 million emergency department visits, and approximately 125,000 hospital admission each year. Just do a screenshot.
I know that you finished the primary care nurse pain management training a few months ago and you haven't had any opportunities to practice your new expertise. But with Jane gone, we're really going to have to work hard to grow your skills to work with pain patients.
Do you need to do this another time?
No. Our absolute priority is patient safety. Adverse drug events, they're a real concern with opioids. And the risks increase with benzos, muscle relaxers, etc. And some of our patients are taking all of them at the same time.
You have a patient?
Adverse drug events and misuse, they are real threats to our patients' lives and to our practice. But you have to watch out because undertreatment is a big problem too. Look, we can get you in more training. Maybe set you up with a mentor nurse at a hospital that has this expertise, but right now, time's up. She's waiting.
I'll get out of your way.
I'll get out of yours. Sorry to throw you in with no notice, but Jane didn't give us any notice either. There is a patient in room 204 waiting for medication reconciliation and counseling.
I'm not ready.
We don't have a lot of these patients, and I promise I will get another RN as soon as I can. You're on.
Change. Some days things change.
This program provides basic guidance on pain management and the prevention of ADEs or adverse drugs events for nursing professionals. The nurse's role in pain management is critical. You have a unique responsibility within the team to counsel and listen to patients, assist in the coordination of care, monitor the proper use of medications. In addition, no one has access to the information that you do. No one can observe a patient's situation quite like you do.
So, first patient, Mrs. Jackson, 38. Ongoing pain from a rotator cuff injury sustained while rock climbing. Her pain management plan includes ice packs and physical therapy, but she will require surgery, which she's been delaying until her toddler goes to kindergarten in the fall. Overall, excellent health. After trying NSAIDs, she became more functional on a low dose of opioids. The dose is being dialed up as she builds a tolerance. You need to make sure she's taking her medications properly and counsel her on a new dose. What now?
So, what do you want to do? Spend time checking the prescription drug monitoring program or see the patient immediately? Well, if you spend time checking the prescription drug monitoring program, you're not really getting enough information about the particular client and you're not able to assess what's really going on. So it's better to see the
So
patient.
you decide to see her immediately.
The prescription drug monitoring program provides a record of Schedule 2 through 4 controlled substance prescription and dispensation information. The prescription drug monitoring program attempts to reduce non-medical use, diversion, and duplication of prescriptions while preserving professional practice of healthcare providers and legitimate patient access to optimal pharmaceutical-assisted care. Healthcare providers are given electronic access to PDMP data in real time at the point of care to improve their ability to screen for substance use disorders, reduce pharmaceutical drug diversion, and assist legitimate medical practice and patient care. Almost every state in the country has a PDMP through programs differ, though programs differ greatly from state to state, and sharing of information among states is not always optimal. Prescription drug monitoring. Prescription drug monitoring programs. What states need to know? Okay. So I'll be reading this later to know more about prescription drug monitoring programs. Okay, let me just do a screenshot.
Mrs. Jackson?
Deirdre.
Rhonda, how are you?
Good.
Good. And how's the shoulder?
My son he's like a little 40-pound maniac bent on destroying the house, toys, other children. I end up having to pick him up. It's painful.
Oh, that's tough. But we want to make sure that your pain is under control safely until the surgery. Did you bring your medicine with you?
Yeah.
And because you didn't check the PDMP, you say,
I just want to make sure that according to the opioid agreement we have, you're not receiving any other pain medicine from any other provider?
No.
Are you taking any other prescription medicines besides these?
Nope, just what Dr. Bright prescribes.
Great.
Oh my God. Okay, so literacy strategies. Warm greeting, greet patients with a smile, welcoming attitude, eye contact, make appropriate eye contact throughout the interaction. Plain non-medical language, use common words when speaking to patients. Take note of what words they use to describe their illness and use them in your conversation. Slow down, speak clearly and at a moderate pace. Limit content, prioritize what needs to be discussed, and limit information to 3 to 5 key points. Okay. Repeat key points. Be specific and concrete in your conversation and repeat key points. Graphics, draw pictures, use illustrations, or demonstrate with 3D models. Patient participation. Encourage patients to ask questions and be involved in the conversation during visits and to be proactive in their healthcare. Teach back. Confirm patients understand what they need to know and do by asking them to teach back directions. For more tools related to these strategies, please use the reference. Okay, HRQ Health Literacy Universal Concussions Toolkit. I'll be reading this later. Go back to that later. Okay, next.
So the pill count is where it should be, and her regimen is fairly simple and free from tricky interactions. She's switching to hydrocodone at this visit, and you're responsible for counseling her on correct use.
There's actually little difference in how you take the new medication from how you took it before, but I want to review to make sure we're doing everything correctly. You want to make
You quickly run through how many and when.
What questions do you have?
None.
What do you want to say? Emphasize, do you know that if you take these the wrong way, there can be serious consequences, including what's that? There's something that's blocking. Just a moment. Physical addiction or even death. Empower. Here are some easy to use resources on the web for information on correct use. Ensure. I want to make sure I explain everything clearly. Can you tell me how you will be taking the new medication? Do you know that if you take these the wrong way, there can be serious consequences, including physical addiction or even death? Emphasize, I want to make sure I explain everything clearly. Can you tell me how you'll be taking the new medication? I want to ensure.
I want to make extra sure that I've explained everything clearly. Can you tell me in your own words how you'll be taking the new medication?
Sure.
So you engage in what's called teach back.
1 to 2 tablets every 4 to 6 hours as needed, no more than 6 in a 24-hour period.
Reading is not teach back. So you ask questions to have the patient frame how she'd take the medication in her words and in her real life.
What'll you do if you have breakthrough pain?
I'd take a second one if the pain gets real bad, but I'd have to wait 4 hours before I take another.
And what if in that same 24-hour period you have a really bad night?
But if I have a really bad night and I'm up, I'd take one every 4 hours and then I'd have an extra.
And you discover a miscommunication.
I'm so glad we went over this because I didn't explain things clearly. While you can take a pill every 4 hours, you can't do that continuously if you've doubled up earlier in the day. So usually people can get by with fewer pills during the night. But either way, don't take more than 6 in the 24-hour period. Otherwise, you run the risk of an overdose.
Got it. No more than 6 in 24 hours.
Now, so tell me, how would you take your medication if you were having a bad day?
I'd take one first thing, 6 a.m., then at 10 or 10:30. Then I'd probably wait until 4 to take the next one because usually midday isn't so bad. Then at 8, and that would leave me with 2 for the night if I have trouble sleeping.
Good. And now, don't forget the other ways to reduce breakthrough pain, like using an ice pack or a heating pad. So tell me, are there any times when you shouldn't take that extra pill?
When I take a sleeping pill?
And your teach back even gives you new information.
I was going to talk about driving, but do you take sleeping pills?
No, but my husband has some.
And how often do you take those?
Maybe once every 2 weeks.
Okay. Well, we should review your opioid agreement and talk about sharing medications. Also, the effect of sleeping pills in combination with your pain meds.
And by having the patient teach back what she understood in the context of her life, you had the opportunity to correct misunderstandings and gained insight into her use. Good job.
Wow. Good job. Thank you. Benefits of teach back. Use teach back, especially when the situation is complicated. Confirm patients understand by asking them to explain your instructions using their words in the context of their life. Studies have shown that from 40 to 80% of medical information patients receive is forgotten immediately, and nearly 50% of the information retained is incorrect. Only 12% of patients are proficient in understanding health promotion. Okay, this is another website where I can review something about patient's memory for medical information. Okay, I'll read that later. Now let's move on. Benefits of Teach Back continued. One of the easiest ways to increase your counseling effectiveness is to employ the Teach Back method with everyone. Even when you think the person may understand, remember, there is not a test of the patient's knowledge of or intelligence. This is not a test. Oh my God, my reading skills. This is not a test of the patient's knowledge or intelligence. This is a test of how well you explain things. Teach Back also allows the patient to practice problem solving in a supported situation. It can be more than an assessment. Even more than an assessment. Ideally, is a coaching session in decision-making skills. For conditions like chronic pain, self-care skills are the key to successful management. Hi, how are you?
Well, I'd like to follow up with you, check in on how the new dose is working. Can I call you?
Sure.
Cell or home phone, and what's a good time?
Cell. And a good time is dancing with my husband at weddings. But call during nap time, between noon and 2.
Okay. That's your husband's nap time, of course.
Exactly.
As you wrap up, you give Mrs. Jackson a handout that summarizes what she needs to know to manage her medication use.
Nurses may be called upon to work on follow-up activities with pain management patients. Follow-up can be as simple as phone call to check on their progress, see if they're taking their medication correctly, and find out if they have any new questions that didn't occur to them during their visit. Contact with patients between office visits can enhance patients' sense of being cared for by your practice. Studies show that patients appreciate and respond well to follow-up contact. After Teach Back, it's helpful to provide a handout that summarizes instructions for the patient.
So you were a little uncertain with your first patient, but she managed to survive your appointment. You made notes in the medical record, set reminders for follow-up calls, and most importantly, you informed Dr. Bright of additional facts you picked up in the conversation.
Just as important as effective communication with the patient is communication with the rest of the healthcare team. Having an observation, getting an insight, or picking up new information from a patient is no one any good if it's not properly communicated in a timely fashion. Okay, I will have to stop this and continue on later for part 2. Okay, see you later.